Atrial fibrillation and atrial flutter are two common indications for antiarrhythmic medications. Atrial fibrillation is the most common sustained arrhythmia worldwide, affecting more than 5 million Americans. Atrial fibrillation is a chaotic rhythm that most commonly originates in the left atrium around the pulmonary veins. It is an irregular rhythm with a variation in the R to R interval with no apparent P waves seen on an EKG strip. Atrial flutter is another common arrhythmia. Typically, atrial flutter often originates in the right atrium near the cavo-tricuspid isthmus. It is a more regular rhythm with consistent R to R intervals and is characterized by a sawtooth pattern of the P waves.
So first, antiarrhythmics act on cardiac myocytes or muscle cells, and they suppress aberrant electrical impulses and slow the conduction through portions of the cardiac cycle. Overall, antiarrhythmics are very old drugs, and they come with several side effects to include numerous drug interactions, especially with amiodarone, which we'll talk about, and often they will necessitate cardiology consultation. The only major indications I included here for antiarrhythmics was for AFib. Obviously, there are other antiarrhythmic agents that are available, and those are used in ventricular arrhythmias, but for AFib, we're focusing really on rate control and rhythm control. So rate control agents that are technically antiarrhythmics as well are the beta blockers in class 2 and calcium channel blockers in class 4. And rhythm control, you'll see amiodarone and sotalol used, which are class 3 agents. So this should look familiar to everybody. This is an action potential in a cardiac muscle cell. And just to refresh your memory, we have several phases. There are technically 4 phases. On the left, you'll see phase 0, which is where the sodium enters the cell and depolarization occurs. At the top, you'll see phase 2, which is where calcium enters the cell and initiates contraction. Phase 3 on the right is where potassium exits the cell and you start to see repolarization. And then once you reach the resting potential, you're back at phase 4. And this is a great slide to show you where some of the classes of antiarrhythmics work. So you'll see again that phase 4 is where you're resting. So you'll see that at both the beginning and the end of the action potential. At phase 0 on the left in that green color is where you'll see class 1A, 1B, and 1C drugs reduce the movement of sodium ions into the cell during phase 0. Phase 1 into phase 2 at the top, you'll see is where class 4 drugs inhibit calcium slow influx, and it lengthens this phase. They also depress phase 4 and lengthen phases 1 and 2. On the right, in the red there, phase 3, this is where class 3 drugs work, and they prolong this phase, which increases repolarization and refractoriness, and then again, you're going to end at that baseline of phase 4. So for class 1 antiarrhythmics, these inhibit the rapid influx of sodium during phase 0, and they act as membrane stabilizing agents. I'm going to skip over class 1A and class 1B agents because these you're rarely going to see in the outpatient setting, if at all. Class 1C agents, flecainide and propafenone, you may see, and you'll see all the way to the right on the picture in the green. For the ventricular action potential, this increases QRS complex, but what it doesn't mention is that even though it just increases the QRS complex here, it's so impressive that it can actually increase the risk of torsades due to a prolonged QT. So in these patients, if you do see someone on these, which should be rare, just to be really cautious of giving them other QT prolonging agents and probably avoiding them if you can. Okay, so for our class 1C agents, which are flecainide and propafenone, you may see these in the outpatient setting, and really they should be reserved only for patients that have no other major risk factors. You'll see again that these are the ones that are going to cause QT prolongation, and they have a very high risk of torsades. They should never be used in patients that have structural heart disease, so if anybody has heart failure or if they're post-MI, they should not be used in these patients. Class 2 agents include most of the beta blockers that you're familiar with. These increase the refractory period by inhibiting beta adrenergic receptors. And so you'll see metoprolol, carvedilol, propranolol, and atenolol in this class. And bradycardia and hypotension are the most common side effects seen here. For class 3 agents, they inhibit the potassium channels, prolonging repolarization in phase 3. They also lengthen the QT interval as a class and, again, predispose patients for torsades. Amiodarone is in this class and interestingly has effects similar to class 1A, 2, and 4 as well. Several side effects are important to note for amiodarone, including drug interactions, which we'll talk about. It's highly protein bound and requires loading for clinical effect, and even a single dose has a half-life of up to 9 to 36 days. So when you're ready to start this in a patient, you really need to be committing to starting them on the therapy. Sotalol is another class 3 agent, and beware of rate reduction in addition to QTC prolongation in this drug, and it's not to be confused with a beta blocker, although it can be considered to have beta blocker properties. So amiodarone I wanted to focus on because this is probably going to be the most common drug that you see in the outpatient setting. It's also one we see a lot in the inpatient setting. Class 3, it's a class 3 antiarrhythmic with action similar to, again, the other classes. It's protein bound, requires loading, and on a stable oral regimen, once they're taking this on a regular basis, it can have a half-life of up to 100 days. It does have a black box warning and several really impressive side effects, including pulmonary toxicity, hepatic injury, and fatal arrhythmias. QT prolongation for this medication alone can be significant, so it's really important to be careful about other QTC prolonging drugs used with amiodarone. It can also cause sinus bradycardia. Like I had mentioned before, it can be toxic to lungs, causing pulmonary fibrosis. It's usually associated with transient liver injury, so you may want to watch LFTs, thyroid diseases, and it can have an effect on the eyes and vision. So interactions for drugs are antivirals, colchicine, azoles like fluconazole, which would prolong the QTC, quinolone antibiotics, which would also prolong the QTC. It does interact with warfarin and can increase INR, statins, and other nodal blocking agents like beta blockers and calcium channel blockers. Amiodarone monitoring I did want to talk about for just a few minutes because of all the potential side effects that you might see. It's important to look at baseline pulmonary function tests as well as annual chest x-rays because of that pulmonary fibrosis. Evaluating semi-annual liver function tests, as well as baseline and repeat thyroid function tests. And the reason for that is that you might see hyperthyroidism earlier in treatment and then hypothyroidism later in treatment as well. Regular is how they defined it, ophthalmic exams. Patients would complain about some sort of visual disturbances. Often they'll see something in their peripheral vision and can also get deposits in the eyes. In the patients that get deposits in their eyes, which happens less than 10% of the time, while it is reversible, it's something that would probably necessitate that you discontinue the medication as it can cause permanent visual damage. EKGs with each visit I don't think is unreasonable, just to make sure their QRS and QT look okay, and then diligent review, again, of their medication list to avoid QT prolonging agents.
Dofetilide, or Tikosyn, is another class 3 antiarrhythmic medication. It requires hospitalization for up to 3 days upon initiation or reinitiation if a patient misses more than 2 doses. Hospitalization is mandated by the FDA to allow for closer electrolyte monitoring and replacement, namely potassium and magnesium. Continuous EKG monitoring during hospitalization is recommended, as there is an increased risk of torsades, mainly seen in trials during the first 3 days of therapy. The incidence of torsades in these trials was up to 3.3%. Initial dosing of Tikosyn is based on renal function and further adjusted during hospitalization based on the QTC interval. Tikosyn can be used in patients with heart failure with a reduced ejection fraction and could be favored over amiodarone in younger patients due to its relative lack of adverse effects. Tikosyn is commonly initiated by electrophysiologists as they are monitoring the EKG closely during the initial hospitalization.
Okay, so class 4 antiarrhythmics prolong muscular contraction by inhibiting calcium influx. They reduce the ventricular rate, and they have major side effects, but are similar to beta blockers in that you can see sinus bradycardia and hypotension. And examples of these are our calcium channel blockers like verapamil and diltiazem. So management and monitoring is really important. So the class 2 and class 4 drugs are extremely common. These are beta blockers and calcium channel blockers, and these are relatively benign, and we know how to monitor patients when they're on these medications. Class 1 and class 3 are specialized drugs that should be followed by a cardiologist, and they need regular follow-up with them. Routine EKGs are essential to track QRS and especially the QTC, as most of these drugs can prolong the QTC, and to pay close attention to the medication list for drug interactions with these medications. It's probably not a good idea to discontinue any of these agents without cardiology consultation.
For completeness, let's discuss two procedures that can be conducted. Cardioversion can be considered in symptomatic, hemodynamically unstable patients. It can be considered in patients with supraventricular tachycardias, atrial fibrillation, ventricular tachycardias, or ventricular fibrillation. It electrically converts patients from these abnormal rhythms to normal sinus rhythm. It can be considered on an elective basis and can be completed in an outpatient setting. It requires uninterrupted anticoagulation for at least 3 weeks before and 4 weeks after the procedure in our atrial fibrillation patients to decrease the risk of stroke. An exception to this rule is when the duration of atrial fibrillation is less than 48 hours. For patients who have not been anticoagulated for 3 weeks prior to the procedure, you can consider performing a transesophageal echocardiography, also known as a TEE, in order to exclude left atrial or left atrial appendage thrombus prior to the cardioversion.
Another procedure that can be conducted to terminate arrhythmias is an ablation. Ablation is conducted when a catheter is inserted into the leg and advanced up to the heart in an EP lab. 3D mapping of the heart is conducted to guide catheter movements during the procedure. There are two types of ablation: radiofrequency ablation and cryoablation. Depending on the arrhythmia, different portions of the heart are ablated due to the origin of the arrhythmia. In picture A, you can see where a line of ablation was performed in the right atrium from the inferior vena cava to the tricuspid valve to interrupt an atrial flutter pathway. You can also see that ablation was performed around each of the pulmonary veins in the left atrium to interrupt an atrial fibrillation pathway. Commonly, these ablations are performed separately. Ablation is a procedure where patients can go home the same day after their bed rest is complete, 6 hours after the procedure is completed. There are complications from this procedure, including bleeding, stroke, and esophageal injury, just to name a few. Ablation is conducted during uninterrupted anticoagulation, and anticoagulation is recommended to continue uninterrupted for at least 2 to 3 months after the procedure is completed. This is due to an increased incidence of stroke that is commonly thought to be highest during the first 24 hours following the procedure, but there is an increased risk continuing for up to 2 weeks. This is due to the heart healing from the procedure, and scabs can form within the heart and break off. It is not uncommon for the arrhythmia to persist during this initial healing process. Esophageal injury can also occur, and this is thought to be due to direct thermal injury to the esophagus, which runs directly behind the left atrium. Temperature probes can be utilized to monitor the temperature of the esophagus during the procedure, and some recommend the use of PPIs for 1 to 4 weeks following an ablation.
So that concludes our discussion of antiarrhythmics. If you all have any questions, please reach out to us before we meet you for class, and otherwise we will go over this when we are with you and incorporate this into some of our patient cases.